I guess that's my opening shot, hit this. And it's my time to go ahead and to introduce our next speaker, who's Audrey El-Gamil. Audrey? Audrey's a senior manager at Dobson-DaVanzo, and she's an expert in health policy analysis, and she's worked with AOPA for many years, but also, kind of ironically, has done projects for CMS. So Audrey, please, thank you.
Good morning, everybody. Thank you so much for having me here today. It is always a pleasure to kind of rejoin the O&P community and talk a little bit about the research we've done. I'm going to talk to you a bit today about the value of O&P services. We've done some economic studies to look at the value both from the patient perspective and from the Medicare perspective. We're going to start with a little bit on the climate. And it's really interesting right now that more than ever, the focus is on value of care. Focus across all industries, not just looking at O&P specifically, but every service is being targeted to say, what's the value of the service? So we'll touch on the climate a little bit and then spend most of our time looking at the results of our economic study. So we looked at the value of O&P services, of orthotics and prosthetic services, specifically with lower extremity orthoses, spinal orthoses, and lower extremity prostheses. I'll review the results with you for that, but then change focus a little bit and talk about value of a different way. So we're going to start with what's the value of getting an O&P service compared to not getting it, but then switch focus and say, once you're going to get a prosthetic, what's the value of the service that you get? What's the value of the specific prosthetic service? So there is a little bit of hesitation in the marketplace for O&P services right now. And a lot of that is because there's an upfront deposit. There's an upfront commitment for providers to pay for a prosthetic device, to pay for an orthotic device. And there may not be a lot of research right now that says, what's the return on that? What's going on? So we know that right now O&P services are a very small percent of all of Medicare spending. We look over an 18-month period and find that orthotic devices are about 2% of a patient's Medicare spending over 18 months. Just 2%, everything else is all the other care they get. But that cost of the device, that small cost, ends up being amortized over the 18 months through reduced utilization in other care settings. And this is where the value proposition comes in. With new delivery systems on their way, you have payment bundling, you have competitive bidding within DME, you get Medicare cuts essentially across the board. Payers in particular are saying, what's the value of a service and do I want to pay for that service? Is there a return that I get by providing a service up front, and will it reduce utilization down the line? So it really emphasizes the component part in saying what's going to reduce my spending, what's going to reduce beneficiary care overall, and do I want to essentially pay for that? So that's where our study comes into play. We are looking at what the value of orthotic and prosthetic services are for the patient and for the Medicare program. We have to have both of those together because benefits for the Medicare program have to make sure they also provide benefits for the patient. So we used 4 years of data, 2007 to 2010 Medicare claims data. This is exclusive to the Medicare population. And we looked at patients that got O&P services compared to patients that did not. And as I mentioned, we're looking at lower extremity orthoses, so those will be your knee, ankle, foot braces, spinal orthoses or your back braces, and lower extremity prostheses, so prosthetics for knee, ankles, foot, all of that. We have followed patients for 18 months and had a custom database from CMS. We have the Medicare claims, very powerful database, and we know every service that a Medicare patient received. So we were able to take a patient that received an orthotic device and find a patient that is almost identical to them that did not receive the orthotic device or prosthetic device. So we're making sure they're clinically and demographically similar. Essentially, we're making twins. And once we get those twins, we're able to say what was their Medicare spending over 18 months and what were their outcomes. How often did they fall? How often were they admitted to the emergency room? What happened during that course of care? So we're looking at Medicare spending and looking at outcomes for these two populations. So what did we find for our lower extremity orthoses? We found great results. We found that patients that received a lower extremity orthoses had fewer falls and fractures, they had fewer emergency room visits, and they had a reduced cost to Medicare. Such a reduced cost, they had essentially 10% lower Medicare spending over the 18-month period. So they amortized the cost of the device. The device was no longer a big driver of cost there. Fewer falls, fewer fractures, and less emergency room visits. Most importantly, as it relates to mobility, patients were able to sustain more rehabilitation, stay in their homes longer, and not be admitted to facility-based care. So in terms of a patient quality of life, to the extent that we can measure it with administrative claims, we have patients staying in their home where they prefer to be, not getting admitted to skilled nursing facilities, not getting admitted to the hospital as often. This chart just shows the trajectory of our spending over the 18-month period. The blue line on top is the comparison group, the patients who did not receive the O&P service, or the orthotic in this case. The red line being the study group. And you can see right off the bat, they start at the same spot, they have almost the same spending, and immediately the patients with orthotic service has lower spending each and every month. When we looked at spinal orthoses or back braces, we found very interesting results. We found that the spending was almost identical, about 0.3% lower for patients that received a spinal orthoses. Essentially what this means is that the spending is almost the same, that the cost of the device is amortized over the 18 months, but on the patient outcome side, we had higher ambulatory and home-based care, again, the patient staying in the home, didn't have as much skilled nursing facility or inpatient care, and all of those signs indicate better mobility. Patients are able to stay where they want to be, able to stay home, and kind of live their lives freely, independently on their own. We did see among this group that they had slightly higher rates of fractures and falls. At first, this could appear to be a red flag, but we actually think that's a positive outcome. These patients are no longer sitting. As Charles said, they're no longer just sitting and dying. They're able to get up and be mobile. While they do have a higher rate of fractures and falls, since the emergency room rates were the same, and hospitalizations were the same, it does not appear that these fractures and falls led to significant other healthcare utilization. They weren't getting hospitalized for these falls. This could have been, they fell, they went to the doctor to get checked out, but they're okay. Again, an indication of increased ambulation and mobility. The trajectory for this group is a little bit different. The study group, the patients that receive the orthotic do start off with a higher cost at first. That's essentially the cost of the device. But over time, their utilization decreases to the point that by 18 months, the lines just cross. Again, it's a 0.3% lower, or $93 on a base of 18 months spending compared to patients that did not receive the orthotic. So lower extremity prostheses. This is by far the most expensive of the categories. But we found patients that received lower extremity prostheses had more home health care. They received extensive outpatient therapy compared to their counterparts. They had higher rates of fractures, but again, we attribute that to ambulation and mobility. And again, despite that, they had about the same rates of hospitalization. They had fewer hospitalizations and fewer facility-based care. Overall, at the end of the day, this group had just slightly higher Medicare spending over the 18 months. It's just 1%, or $728 on a base of 18 months, on a base of $68,000. So it is slightly higher, but what's more impressive is that these devices are very expensive. And the decrease in utilization in the other care settings made up for the cost of the device. So I started by saying policymakers are a little bit hesitant about the upfront commitment of O&P services. This indicates that by getting the prosthetic device, that cost essentially is nullified. You're reducing utilization everywhere else. And of course, that results with better quality of life, increased independence compared to patients that didn't get it. This line is very similar to the orthoses line. You have the study group being more expensive at the front end, but over time with the decrease in utilization, lower hospitalizations, lower ER visits, the spending becomes just about the same. So what does this tell us? This tells us that orthotics and prosthetic services provide value to patients and they provide value to the Medicare program. Overall, we have fewer hospitalizations, we have lower facility-based care, more outpatient rehab services with the same or lower Medicare spending across these three groups. So there is a risk of slightly higher falls, but we attribute that to an indication of, like I said, ambulation and mobility. Patients are getting around. Patients are actually able to live their lives independently without necessarily higher risk for hospitalizations or ER. So overall, we think this indicates a tremendous value for both the patient and for the Medicare program. So we look at this now a little bit differently. So we just talked about the value of getting an O&P service compared to not getting an O&P service. But now let's talk about a little bit of once you're going to get a prosthetic service, how do you maximize the value of that device? And there has been some concern in the industry that prosthetists may be providing prosthetic devices that are beyond the needs of an individual patient in order to have a higher Medicare payment. So we wanted to challenge that. We said, if you're going to get a prosthetic device, how do we make sure that you are getting the one that provides the most value for the patient? So we looked at patients that have an orthotic, that have a prosthetic device that was appropriate for their functional level. And the Medicare claims provides what's called a K-level assessment that essentially is what is the functional level of the patient. So we looked at patients that got a prosthetic device that matched their functional level. And then we looked at patients that got a prosthetic that exceeded their functional level. So if they are a more low functioning patient based on physician assessment, did they get a device that exceeded that was meant for a more mobile individual? So we're comparing those two populations, those that got one appropriate and those that got one that exceeded it. And again, this is referred to as the K level, where a K1, for the purpose of this analysis, is a lower functioning individual, and a K4 would be a higher functioning individual or a higher functioning device. So I want to draw your attention to the top right corner. We have the distribution of Medicare beneficiaries based on their K level. And we found that 95% of patients in the Medicare population that we're looking at have a K level of a K2 or a K3. We also realized that beneficiaries with a K3 with a slightly higher functioning device had lower Medicare spending over an 18-month than the K2. What's interesting about this is that the K3 device is more expensive, so that population had higher DME costs, but they had lower SNF costs, lower home health costs, and lower spending in many other categories. This again comes back to the amortization of devices. Beneficiaries in K3 are able to get a more functioning device, a more sophisticated device, and reduce utilization in other areas that the overall Medicare spending is lower for this population. So we wanted to test our theory. Say, what happens if a patient gets a device that is upgraded, they get a more sophisticated device, and compare it to a patient that got an appropriate device. And you see in the bottom right corner that a patient who gets an appropriate device has about $81,000 in Medicare spending over 18 months. But a patient that got a device that was one level higher or one level more sophisticated than their functional level had lower spending of $80,692, and a beneficiary that got a patient that was 2 levels higher had a Medicare spending of about $70,000, even lower. So what we take away from this is that while getting an upgraded device results in higher DME costs, it also results in overall lower Medicare spending. So there is a point right now that will say that Medicare beneficiaries or getting an upgraded device results in lower healthcare utilization and the cost of the device is amortized. But as always, outcomes are more important than Medicare spending at times. So we wanted to see how the outcomes differed. Did a patient that got an upgraded device have different outcomes than a patient that got the device that was appropriate for their functional level? And the important line here is essentially looking at falls. Beneficiaries that receive an upgraded device had slightly higher falls. They had a higher risk of falls. But no other healthcare utilization was different. They had no change in hospitalizations. They had no change in mortality. They had no statistically significant change by getting an upgraded device compared to somebody who got an appropriate device. So if we step back, we know that patients that got upgraded devices had lower Medicare spending significantly, and they had a slightly higher risk of falls, which we attribute to ambulation and mobility, but they had no other outcomes being different. So to us, this indicates that there is a true value of possibly considering or true value of getting devices that are possibly beyond your functional ability, your functional status. And this may be a policy that, or this may be something that indicates that right now the current policy that beneficiaries should not be getting upgraded devices may be too restrictive. And there is value in this industry to kind of consider loosening a restriction and allowing beneficiaries to get the device that's most appropriate for them as identified by a physician, which could result in lower Medicare spending with equal, if not better, outcomes. So now I want to switch gears a little bit, kind of out of the value, and talk a little bit about what Charles introduced, which is a law that has that requires O&B services to be provided by certified individuals. We wanted to look at the growth of O&P services by provider type. And essentially what we did is we looked at the composition of who is providing care right now. So we took 3 licensure states, we took Florida, Illinois, and Texas, and said who's providing Medicare services. As Charles mentioned, they're supposed to be provided by a certified orthotist or prosthetist in an appropriate facility. And we found that only about 1/3 of O&P services are in fact provided by certified orthotists or prosthetists. 1/3 are provided by physicians, and the remaining 1/3 are provided by non-certified entities. This is a medical supply company that doesn't employ a certified orthotist or prosthetist. This could be a pharmacy, it could be a laboratory, it could be any other setting that does not currently employ an orthotist or prosthetist. So this is something to kind of keep an eye on, and it's something that we're actually continuing to look at with upcoming analyses. So we're underway on a study that looks at the provider of care. How does the provider of care affect outcomes? Do patients that see an orthotist or prosthetist have different outcomes in Medicare spending than a beneficiary that goes to a physician or a beneficiary that goes to a non-certified entity? We're also looking at a study to look at the projected supply and demand of orthotists and prosthetists, as well as many other professions within the O&P field. And as the value proposition comes into play, as it will for the next many years under bundle payment and delivery reform, we want to make sure that there is a supply to meet the demand so that beneficiaries can continue to receive these valuable services. I think a last closing point is that the industry now is armed with significant amounts of data. There is the study that we just presented to you. There is also this massive database that we have used that underlies it that has tons of answers that just need to be mined, essentially. So with good data resources, the industry can continue to demonstrate its value and to do studies like this to make sure that policymakers, providers, payers, everybody and above can say, yep, I see the value of O&P services, and we can make sure that beneficiaries continue to receive those services. All right, thank you very much.